now I invite Dr. Kiran for his talk on multimodal imaging in CSCR. Now, Dr. Kiran has an extensive experience with multimodal imaging, and he can be called a literal expert on that. Over to you, Dr. Kiran.
Thank you, Jyoti sir, for the introduction. I'll be talking on multimodal imaging in CSCR. So CSCR can be diagnosed clinically, and even non-invasive modalities, especially commonly used OCT, can be enough to diagnose a case of CSCR. But additional multimodal imaging using FFA and ICGA can assist in CSCR treatment modalities and provide insights into the choroidal changes also associated with the disease. So as I said, OCT is the most common imaging modality for evaluating as well as following up cases of CSCR. So when supplemented with enhanced depth imaging, it can even evaluate the minor details of the choroid and gives information on the subfoveal choroidal thickness. So as already mentioned, the CSCR is part of the pachychoroid spectrum entity. And by pachychoroid, there is the exact definition is still debatable, but the broadly accepted definition is between the range of 300 to 395 microns. In acute CSCR on OCT, you get this picture where there is subretinal fluid collection, and there's elongation of the photoreceptor outer segments, which you can see over here, and this happens to be due to the lack of phagocytosis by the RPE, that is dysfunctional RPE. So associated findings of CSCR can also happen in the form of small PED, like serous PED. And over here, what you see is like the sagging or the dipping of the posterior of the neurosensory retina. And there is a small RP rip exactly over here, and a fibrinous material covering it. And there's an appearance of a vacuole sign. And these are sites of fluid egress in CSCR. So you get, when you do an FFA, you get a leak at this corresponding to this region. Then subretinal hyperreflective material in CSCR was initially reported by Gas and colleagues, and is more prevalent in pregnant women and those with history of steroid intake. And the exact material or composition is still not clearly understood, but is likely to be due to proteinaceous materials mainly composed of fibrin. So this is a case of fibrin CSCR where you can see a subretinal lesion, yellowish lesion surrounded by subretinal fluid. And FAF shows hypoautofluorescence corresponding to the lesion due to masking of the background autofluorescence. On fundus fluorescent angiography, you get an ink blot pattern of leak, which is very obvious in the late frames. And on SD-OCT, a subretinal fluid is seen with subretinal hyperreflective material corresponding to that yellowish lesion clinically. And all these features give an idea that the patient has got an element of fibrinous component of CSCR. Chronic CSCR happens when there is persistence of subretinal fluid for more than around 6 months duration, and this leads to morphological changes in the retina. So the changes start from the outer nuclear layer, ellipsoid zone can be affected, and even in when the disease progresses and when the disease reaches a state of chronicity, you get cystoid changes called as cystoid macular degeneration. Intraretinal and subretinal hyperreflective dots are again signs of chronicity. And flat irregular pigment epithelial detachment, as you can see in this diagram over here, involves elevation of the RP from the underlying Bruch's membrane. It indicates that there is definitely an element of macular neovascularization developing, and you need to follow up these patients very carefully. So OCT prognostic factors include hyperreflective dots. It can be either in the inner retina or even the subretinal layers. So the above figure shows hyperreflective dots in the inner retina as well as subretina and even overlying the RPE. And the bottom figure mainly confines to the photoreceptor plates and above the RPE. So the presence of these dots, as I mentioned, are indicators of poor visual acuity and chronicity. Cystoid macular degeneration, large cystoids can be seen. These are degenerative cystoids and associated poor visual outcomes. Outer retinal changes needs to be carefully analyzed because they again give an indication of the visual status in these patients. The disruption of the second hyperreflective band, that is ellipsoid zone, the overlying external limiting membrane, the outer nuclear layer thinning, they are all indicators of poor visual outcome, especially if they involve the fovea. On fluorescent angiography, you get multiple leak patterns. The most commonly observed ones are the ink blot followed by smokestack. And you also get pooling of the dye in areas of serous macular detachment, and it occurs due to collection of dye within the enclosed space. So here's an example of ink blot pattern where there is progressive and uniform expansion of this hypofluorescent spot from the early to the mid, and there's leak from that area from a central pinpoint. This is a smokestack pattern in which there is ascending hypofluorescence followed by lateral diffusion of the dye in a mushroom-like configuration towards the late phases. This is a minimal enlarging spot in which there is a small hyperfluorescent spot, but it sort of fades away in the late phases. There's no, it's very difficult to even say if there is an obvious CSCR leak in these patients. So chronic CSCR shows mottled areas of hyperfluorescence due to widespread window defects or RP atrophy. FFA can also detect the presence of macular neovascularization. ICGA can be categorized, changes can be categorized in early, mid, and late phase findings. In early phase, you get delayed filling of the chorioid capillaries and choroidal arteries. In mid phase, focal choroidal hyperfluorescence can be seen, mainly due to choroidal vascular hyperpermeability. Dilated choroidal vessels can be also seen. And towards the late phases, you get the stipple hyperfluorescence spot, that is punctate lesions, mainly because of transient hyperpermeability of the choroidal vessels, which fades away towards the late phase. ICG also helps in identifying MNV that complicates CSCR, and it appears as ill-defined lesions with late-staining plaques. Associated polypoidal choroidal vasculopathy can also be diagnosed since it's because overlap cases can occur with CSCR. The vortex veins can be identified very beautifully using the wide-angle systems. So this is a case which shows defects involving the retinal pigment epithelium at the macula. On fundus fluorescent angiography, you get an ink blot leak. ICGA demonstrates hyperfluorescent nodular lesions, which signifies the presence of polyps in this area. So you've got a coexistent polypoidal choroidal vasculopathy like picture with CSCR, and this is confirmed using an OCT scan where you get a typical notched PED corresponding to the polyp with adjoining subretinal fluid as well. ICG also helps in guiding treatment using photodynamic therapy, and PLACE trial which was done recently is an important guide for this. Fundus rhodopluorescence is an important marker of both photoreceptor and RPE function. Lipofuscin, which has got autofluorescence property, it accumulates within areas of dysfunctional RPE and due to incomplete phagocytosis of these photoreceptors. The two types of FAF imaging techniques, that is short wavelength and near infrared. Short wavelength originates from the lipofuscin present in the RPE, whereas near infrared gives information about the melanin from both the RPE and choroid. So different autofluorescent patterns are seen in acute CSCR. You get area of hypoautofluorescence in acute CSCR due to fluid collection, and areas of hypoautofluorescence can also be seen corresponding to areas of leakage on fundus fluorescent angiography. In cases where FFA is contraindicated, even you can use FAF as a tool for treating these patients with focal laser. In chronic CSCR, you get different patterns like diffuse hyperfluorescence in the early changes. More than 4 months changes, you can see as like a granular pattern of hypo and hyperautofluorescence, and in long-standing cases, you get diffuse hypoautofluorescence. So nice gravitational track can be seen on FAF in this patient, and corresponding window defects are seen on FFA, and the OCT shows widespread loss of outer retinal bands. OCT angiography in CSCR helps in picking up subtle networks which may be missed on FFA and ICGA. And the presence of flat irregular PED is an important indicator for presence of MNV. This case, you can see RP defects at the macula, subretinal fluid is present, and just below it, you can see a very subtle elevation of the RP and from the Brooks. FFA just demonstrates triple hyperfluorescence. IC8 does not show much changes except for the dilated choroidal vessels. Octa is extremely sensitive in these cases because of beautiful networks in the sub-RP level, indicative of type 1 CNVM in a case of CSCR. Again, over here, this is the last example which shows only subretinal fluid and hyperreflected dots initially. FFA is again very inconclusive. There is no network on Octa. 6 months after half fluence PDT, you get what appears as an RP elevation and shallow subretinal fluid. And after 3 loading doses of Eylea, which this patient received, the OCT sections are dry, but you get a network which is forming at sub-RP level. And after a complete course of 6 Eylea injections over a 3-year follow-up, you can see how beautifully the network is increasing in overall size and extent, but there is no fluid again, but the PED height is increasing. So we need to keep these patients on close follow-up to both educate them about the need for maintaining those follow-ups and also for that whether they need treatment should the disease activates. So thank you.
Excellent presentation.